an auto and something to fix centrals together. You have auto EPAP, automatic EPAP, get rid of the OSA. The pressure support is automatic, so it gets rid of that periodic breathing. If they completely quit breathing, you got an auto backup rate, and that gives you the ASV. Very comfortable machine to wear. Our machine, difference, Philips and ours, the only two out there, at least in the US, we look at minute ventilation, they look at peak flow. They both are trying to do the same thing, it's just different mechanisms. And we were out there probably 6.5 years first, so it was patented, so they couldn't go there. But this is how ours looks at minute ventilation. It looks at 3-minute window. They look at a 4-minute. And it's continually adjusted as they breathe. Constantly looking at it. In this case, the patient's moving pretty good. But when he drops down, he's not breathing as much. The machine immediately sees that and actually increases the pressure support. And then when they come out of it, now they're breathing, it backs back off. So it's constant, it can be constantly changing, very comfortable to breathe on, prevents under and over ventilation by constantly responding to that. But the point of it is, if the airway's not open at all, you can't ventilate them. And so you've got to have an auto EPAP. Well, someone has to adjust the EPAP. You can do just ASV where the sleep tech controls the EPAP, or you can do auto where the machine controls it. And this is actually the way ours works exactly. It's looking at minute ventilation, so they're having an apnea. The flow drops, which drops the minute ventilation, and the machine sees that, and it immediately increases the pressure support. So it goes up. And if you do increase the pressure support and the airway's open, you're going to see a response. It's going to be a response in the flow, and it sees that and goes, oh, okay, airway's open. So I'm ventilating the patient now, so I don't need to touch the EPAP. But if it's an obstructive apnea, it does the same thing. The flow drops, the minute ventilation drops, increases the pressure support, but the airway's not open. So it kind of bounces back like radar. It knows, well, the airway's not open. That's a closed airway. That's obstruction. So then on the next breath, it increases the EPAP. Okay. And I believe, yeah, and this is actually on a patient. You can see here, you can see just quickly the flow dropped. This is the target that it's looking at, minute ventilation. So it drops a little bit, and so it sees that, so it says, hey, what am I going to do? I'm going to increase the pressure support. So when it does actually impact the flow. So it's pretty close to what it was. So pressure support jumps in there, goes, okay, that was a central then. So I don't need to touch the EPAP. But over here, the next one, the flow drops again. Down here, this is actually an obstruction. So it immediately tries again to do the pressure support, but it's not doing a whole lot because the airway's shut down. So it sees that, says, hey, minute ventilation drops. I mean, it drops quite a bit because he's not doing anything. Pressure support's trying to fix it. It can't. So, okay, that's an obstruction. So on the next breath, it increases the EPAP to clear the airway. So it's constantly, both algorithms are working, and so it will actually take care of it pretty well. And this is why it's more comfortable. Every single breath, it looks at 13 points in every single breath to know when's the next breath going to happen. When, if he doesn't breathe, should I put in a breath here? When do I increase the pressure support? So it's constantly, every single breath, it's looking at all these points, and it's a very sine wave. This is the way it's looking. Why we normally breathe, we call it easy breathe. And I believe it's CFX Plus. I think that's what they try to do, this waveform on Philips. But again, it's all about comfort. The guy that originated the algorithm, Michael Berthan Jones, said he wanted to have a CPAP that heart failure patients would wear because they didn't like the way it was pushy. BiPAPs were pushy, so this is more natural. And so it's just very much more comfortable. Now here's this patient, that same patient. And again, there's where they switched him from CPAP to ASV mode, and now you can see it ventilating, and it starts to normalize. And even the SATs stabilize a little bit, pulse rate, less variability, until eventually it's pretty much normal. And the interesting thing is, as long as they wear the machine, it's fixed. As soon as you take them off the machine, they'll start doing it again. So it's not like you cure them, you just make it go away while they're wearing the machine. So then the last one, volume assured pressure support. Hybrid modes that you can guarantee the volume. Using pressure support because it's more comfortable, but now you're guaranteeing a volume. So it's been used a lot more, and it's probably on a lot of the hospital vents too. And again, this is what we do in our machine, which is IVAPs, and then Philips is AVAPs. We look at minute ventilation again, and this is the little target, and basically it's looking at the target. When the guy drops below the target, it increases the pressure support. So you give it a range of pressure support, and you tell the target, hey, I want to ventilate this guy at 500 mils. And so it looks at every breath and will compare it and actually increase if it needs to. And again, you get more stable ventilation, especially when they're sleeping. Meaning many of these patients do well in the day. It's just when they go to sleep, they don't have their accessory muscles. Diaphragm doesn't work that well. So it'll just ventilate them like they do in the day and actually let them sleep better. Reduce the work of breathing, adequate levels of treatment pressure. And this is huge as far as making it easy. And what kind of patients? Again, they're really for adults, 66 pounds. COPD is a great option. Obesity, hyperventilation, neuromuscular, all those are good options, but unfortunately, you've always got to see if you're going to get paid for it, because this is in a backup rate machine, which you got to jump through more hoops, or you could do it in the ventilator too. But yeah, you always have to keep an eye. Great therapy, but is someone going to pay for it? And again, the difference, Philips, it's AVAP's average volume assured pressure support. Ours is IVAP's intelligent volume assured pressure support. Biggest difference is they look at tidal volume and we look at minute ventilation. A little bit different, trying to do the same thing. In the Trilogy, they have an automatic backup rate, meaning you can set it if I understand Philips correctly, and if I'm not, Philips jumps in. That I think in the first few minutes when the patient's on, if you put in auto mode, the first few minutes, it actually learns their rate, and I think sets the rate to below what they breathe at. Our automatic backup rate, a little bit different. You actually put a target in there, what they normally breathe at, and it tries to maintain that target. It lets them, has a backup rate at 2/3 of that, but it will actually ventilate them at that rate. And they both have automatic EPAP in the ventilator. So a lot of similarities. The algorithms are different, response rate is different, but their purpose is the same. And so you're thinking, why do I even do this? Bilevel is pretty comfortable because it's on flow. The challenge is that in a regular bilevel, you can't guarantee a target. 15/5 could be different when they're laying on their back, and they roll on their side could be different. Whereas this one, you set a range of pressure, so they roll on their side. If the volume's too low, the machine immediately compensates, jumps up there with pressure support to get the target that you set it. And again, the control, I think it's comfortable because the patient's controlling their own breathing. They're controlling when the breath starts and they're controlling when the breath ends. And again, using the VAPS mode, still comfortable, but yet now you're guaranteeing things. Whether it's positional or in a sleep stage, you're going to still deliver the volume. So, review, knowing these patients, it's so helpful to know the diagnosis, but that will clue you in. But even if you're watching them, CPAP may not be the perfect choice. The goal of therapy will tell you what the machine. Are you trying to stabilize the airway? Probably CPAP's going to work, or an auto. If you're trying to ventilate the patient, you're going to have to go to a bilevel or a ventilator. Stabilize the patient's ventilation. Maybe it's an ASV. And if you need delivered volumes, guarantee them, then probably the VAPS mode on a ventilator or on a bilevel will work. But one of the key things to remember, unlike before, you can do bad settings. It's going to happen. You're going to do goofy settings. But the neat thing now is, because everything's wireless, you'll know the next day if you're monitoring them, oh, those maybe aren't the appropriate settings. You can go in and change them immediately. Compared to the old days, you'd wait till you see them 30 days later when you found out that it's been sitting as a doorstop for the last 3 weeks. You're going to pounce on them now, and you will know that. There's no excuse not to know that because the technology is there. And so you can do some goofy settings, and you'll be able to respond immediately to fix that. Any questions on anything? Thank you.
Any questions for Gary?
Thank you very much.
Quiet bunch. Thank you, Gary. So,